All right, guys, how's it going? It's Cam, and I'm bringing you guys a quick seminar to do with geriatric cardiovascular differences and the associated heart disease. So, a couple topics we're going to be covering. First of all, it's going to be fibrosis of the cardiovascular system, and also fibrosis of the vasculature and associated hypertension that's involved with that. We're also going to be covering left ventricular systolic and diastolic function, and rather the dysfunction that occurs with geriatric population, and also age-related heart failure and arrhythmias that occur with these patients. Compensation deficits will occur throughout the presentation, and if you have any other questions involving this subject, just give me a text or give me an email or find me in class, and I'll be happy to explain this to you. Okay, so to begin, we need to go over some anatomy and physiology, just so we are all on the same page. So we know that the heart has two sides. We have the left side and we have the right side. So blood will start, let's just start from the normal side. So we'll start in the right atrium. It'll go through the tricuspid valve into the right ventricle. And this is deoxygenated blood returning from the systemic circuit. So this deoxygenated blood will go through the pulmonary valve from the right ventricle and will filter through the pulmonary circuit and will enter the left atrium again. And once it returns to the left atrium, the atrium will contract and we'll send it through the mitral valve or the bicuspid valve into the left ventricle. And now this left ventricle will contract and will force it through the aortic valve into the systemic circuit. So we also need to go over what the actual myocardium itself is made of. And also just remember that the septum is a piece of a muscle, myocardium, that separates the two. So myocardium itself is made up of a couple of different things, but the three things that are most important for this presentation are the actual myocardial cells themselves, the fibroblasts, which are these little green, the gray guys right here, and collagen. So we'll just go over a quick thing. So we know cardiac output is the amount of blood moved within a minute of the heart, and it's made up of heart rate, which is how many times it beats per minute, and multiplied by stroke volume. So the stroke volume is how much blood returns into the systemic circulation after every beat. So stroke volume is controlled by three things. So we know preload, which is the amount that enters the atrium or enters the heart itself, rather. Afterload, which is the amount of force it's fighting against to contract. So a couple examples are valves or the vessels themselves, or the pressure that the vessels are under. So the systemic pressure would be your afterload as well. Contractility is the force that the heart actually contracts with. So some cardiac functions we need to remember because they do come into play later on, actually the next slide. So systolic function is the ability for the heart to actually contract and inject the blood that's within it. So the systolic function of the ventricle, for example, would be to get rid of the blood that has entered it. So on contrary to that, a diastolic function is the ability for the heart to actually relax and allow blood to actually enter and fill the space. So the diastolic function of a ventricle would be it's allowing to relax and allow the atrium to send blood back into the ventricle. So these two functions put together allow the heart to beat and actually move blood within the body. Okay, so let's begin by start talking about fibrosis within the heart. So it all starts with systemic hypertension. So the systemic hypertension will really be affecting the aorta right here and the aortic valve. So this systemic hypertension will increase the afterload due to the amount of pressure that the actual aorta is under, and therefore affecting how much pressure is being sent to the aortic valve, blocking its opening, because it only opens one way. So when that happens, an issue within the heart occurs, and that is that the heart actually works harder to send this blood through the aortic valve. So when this happens, an increased workload is put onto the heart. So that heart needs to work harder to overcome this afterload, and therefore a couple changes occurs. So first of all, the myocytes start to begin to hypertrophy, and this is due to the increased workload, increased need of contractions, so they begin to hypertrophy and grow bigger. Um, in addition to this, collagen and fibroblasts begin to form due to the increased stress. So we can see that right here. This is a normal myocyte, and these are the hypertrophied myocytes right here. And right here is our collagen and fibroblasts actually forming and causing it to be less efficient and cause some problems. So with the hypertrophy, it takes up more space, and therefore we start to progressively lose myocyte numbers. So that becomes to be an issue. And we also see fibrosis because of that collagen and fibroblast formation. We start to see a fibrotic tissue growing within the left ventricle, and that's what we know as ventricular fibrosis or cardiovascular fibrosis. So when this occurs, we start to see systolic and diastolic dysfunction. So this portion of the flow chart right here only applies to systolic and diastolic dysfunction. So what happens when this occurs is that three things. So we'll start with here. We'll talk about systolic dysfunction. So how does this hypertrophy and fibrosis really affect our systolic abilities? So when we start to lose efficiency in our myocardial cells, we start to see a loss in systolic ejection. So when we start to see the efficiency lower, our myocardial cells are not able to contract as well, and we have the fibrotic tissue involved, we start to see a drop in systole and systolic contraction capabilities. So then we see our first dysfunction, which is systolic dysfunction. So on the contrary, we also see diastolic dysfunction, and that is due to the hypertrophy involved. So we see a dotted line here, and this is representing the hypertrophy that will occur within the ventricle. So as we can see here, if we hypertrophy, we start to lose ventricular space, some real estate involved, we start to lose it, and we lose that space, and because of that, we start to lose blood space. So that blood that would have been going right here, being sent here, is no longer able to enter the ventricle. So because of that, we lose diastolic function, and diastolic dysfunction occurs. So our third thing that really affects the heart's capabilities is asynchrony between the ventricles. And because of our ventricular hypertrophy that's occurring on the left side takes a longer time to contract and relax and function as needed. And the other side of the heart, the right side, actually doesn't really undergo these changes to that extent. So then we start to see a loss in synchronizing between the two. So all three of these things lower your stroke volume, and our stroke volume really affects our cardiac output, therefore affecting our ability to perfuse. Okay, so let's talk about how systemic hypertension actually occurs within the geriatric population. So we all know hypertension is increased blood pressure, but geriatric hypertension really in itself is hypertension that is occurring in patients 50 years of age or older. So the onset of hypertension after 50 years of age. So this hypertension is really only systolic hypertension, and I'll explain why. So systolic hypertension, I'm just going to draw out a couple blood pressures here just to explain this. So the one on the left that you see, the 120/80, that is a normal blood pressure. So we have a pulse pressure of about 40 here, because a pulse pressure is the difference between the systolic portion of the blood pressure and the diastolic. So if you take 120, subtract 80, you'll get 40. Oh, and I wrote 44, that should be 40. Okay, so that's normal. So when we get to systolic hypertension, we see only a difference within the systolic portion of the blood pressure. And if we do the same math that we did before, 160 minus 80 will be 80. So now the pulse pressure is 80. So that really puts it into numbers to explain that systolic hypertension really does widen out your pulse pressure. So how does this occur? Really, with aging, there's a couple differences that occur within the vasculature of the body. And the first thing that occurs is that the phenotypes within the endothelial lining actually start to change. So we start to get pro-inflammatory, pro-thrombotic, and pro-constrictive phenotypes within the endothelial lining. So these differences will start to cause inflammation. They really explain themselves. So they cause inflammation. They also start to constrict. So they inflame, they start to get thicker. So we'll see, oh shit, we'll start to see a thickening of the lining, and we'll also see it constricting as well. And the third thing that occurs is prothrombotic phenotypes start to develop, and that really affects when atherosclerosis becomes involved. We start to see the plaque that's building. We start to see those phenotypes really affecting this plaque in terms of causing a thrombosis that occurs. So all three of these phenotypes really they start to develop the endothelial dysfunction, and that narrows the vessels. So a second thing that happens is that vascular remodeling also occurs. So within the vasculature, there is remodeling. So we start to lose elastin, we start to gain a lot of collagen, and we can start to guess where this is going. So the more that collagen and the less elastin that is present starts to drop our elasticity of the vasculature. So therefore, it can't stretch when it needs to, and it can't accommodate that higher blood pressure that is going to occur. So the third thing that occurs is vascular fibrosis, which is actual fibrotic tissue that starts to develop, and that is due to the fibroblast presence actually increasing. And we can see that here, which is these gray guys right here. So the stiffening of vasculature is what occurs because of the fibrosis, and with all three of these changes occurring, we do see a raise in systemic systolic blood pressure. So within the whole body, our systolic blood pressure goes up, and that really does make a lot of sense if you think about it, because with every heartbeat, there's more blood within the systemic circuit, and if the body can't actually accommodate that space with elasticity or with any sort of other compensatory mechanisms, it really affects the blood pressure. And with it also stiffening and narrowing, it furthers the pressure building within the vasculature. And we can actually see that on a mathematical level. If we look at our formula here for mean arterial blood pressure, if our vessel size increases, we also see an increase in systemic vascular resistance, and that will affect our afterload. So our afterload will raise, our stroke volume will lower, and therefore our cardiac output will also lower. So we're going to move on to cardiac electrical conduction. So right here in front of us, we have a normal cardiac electrical system. So we have the anatomy of it and associated ECG to kind of explain the process and what we see in each portion of the ECG. So first of all, we're going to be going phase by phase through these phases right here, as we see at the bottom of the screen. So the first phase we see is isoelectric line, and that is the portion between ECG complexes and in between heartbeats, really. So we start to go towards phase 2, which is a P wave, and that P wave is the actual contraction of the atria, and that occurs in this section right here. So you'll see it highlighted right there. So the SA node originates beat from 60 to 100 beats per minute, as we know, and it sends that signal through the AV bundles, as we can see right here, this little loop between the SA and AV node. And it also sends signals through the Bachmann's bundle over to the left atria. And therefore, that's controlling that both atria do contract. Then we get to our PR segment. So we all know our PR interval, and that is the entire space right here, and that's where we can start seeing blocks and that kind of thing, and diagnose that kind of thing. But we haven't really talked about a PR segment, and the PR segment is really um, the amount of lag that the AV node undergoes before sending it out to the ventricles. So that PR segment is really the AV node taking a second, processing, and then sending it to the rest of the heart. And then we start to approach the Q wave and the QRS complex in general. So the Q wave is really the Q wave is hiding atrial repolarization, and it's really the beginning of the ventricular contraction. So the QRS is when the signal travels through the bundle His and then bifurcates at the bundle branches. And also it then follows down through the bundle branches, and then it reaches these tree-like figures right here. And these are the Purkinje fibers. So as the electricity floats through, it goes through Purkinje fibers and signals for the entire ventricle to depolarize. That occurs, and we see a large positive spike on our QRS, and that's why it's such a large spike in comparison to every other wave or complex that we see on the ECG. So then we get to our ST segment, and that is the portion where there is no electrical activity involved within the heart. And then we approach our T wave, which is our primary electrical cells repolarizing. And that is only in the ventricle because the atria is already repolarized. So the primary, what I mean by primary, is the bundle of His and the bundle branches, and the more primary locations of the Purkinje fibers. So these guys right here, those guys all repolarize, and the majority of the repolarization of the heart is complete. So now we get to our step 8, which is our isoelectric line, and that is again no movement whatsoever in the heart in terms of electrical conduction. And then we approach phase 9, which is really widely unknown, actually. A lot of students actually don't know what a U wave is, and really a lot of scientists and researchers don't really know either. But the best guess of what a U wave is actually the repolarization of the more distal portions of the Purkinje fibers. So these guys right up here, for those guys to repolarize, takes a bit longer. We're not quite sure why there's an isoelectric line between them two. And really, we don't see them in the majority of our patients, and we only see them really when there's a T wave that is depressed. So hypokalemic patients, for example, something like that. And you might see them on readouts, you might see them in other patients, and really, there's no lethal or life-threatening event occurring. However, we do want to know that they do exist, just in case you do see them. So now that we understand normal cardiac electrical conduction, we can start talking about geriatric arrhythmias. So really the basis of arrhythmias is cell aging and fibrosis of those cells. So we'll first start on the nodal degeneration portion of this chart, and we'll start talking about at the SA node, because really nodal degeneration causes all three of these issues that we see right here. So if we take a look at our SA node, we start to see nodal degeneration within the node itself. And when this nodal degeneration gets to about 90% or so, it starts to have a really hard time sending P waves and actually sending that electrical output that it normally does. And we'll see that in terms of, if I draw it out, I'll show you. So we'll see our P waves, which is our SA node actively kicking a normal electrical current at the rate that it needs to. As AFib occurs and as the nodal degeneration occurs, it'll have actually a hard time creating this current and sending it out. So what we might actually see this instead of our P waves. So obviously this QRS is involved, but at this point I'm just trying to show you atrial involvement. So that will occur. There really is no studies showing that this portion of the heart of Bachman's bundle showing like a partial AFib that's not really studied, that's not really proven to be um, existing, so we're going to not mention that. Our second portion that we're approaching is our AV heart block. So AV nodal heart blocks, and that is these are very lethal. All three of these, sorry, are life-threatening in their own ways. However, AFib and AV heart blocks are proven to be severely detrimental to our patients. AFib more because of clotting, and that's because of the contraction involved with the atria. If it's not actually contracting at a full speed, there might actually be blood that is hanging out at the most distal portions of the atria, and will actually start to partially coagulate. And when those are actually finally transmitted through the body, through our pulmonary circuit, we start to look at possible PEs, strokes, MIs, that kind of thing. So our AV heart blocks, they occur at our AV node. In our AV node, what happens is that the AV node, once there's an issue with conduction through the AV node, we'll start to see some deficits. So when the nodal degeneration occurs on the AV node, we'll start to see a beginning of our first degree heart block, which is an increased PR interval. And that occurs because it's having more of a hard time transmitting the signal out past the AV node. And so our PR segment is actually increasing. So the PR interval is also increasing, but it's really the segment we're looking at. And the P wave doesn't change too much. It does widen slightly depending on where the block originated, but AV nodal heart blocks are really the PR segment that's increasing. So as we start to progress into second degree heart blocks, we know our type 1 and type 2, so the progressive widening and then a drop, or just a widening and a drop, or just a random drop with no widening. That's really depending on where in the AV node the heart block is occurring. But the third degree is really when we start to get worried, because that means that the entire node, the entire node has degenerated, and that there's a complete and absolute block between pre and post AV node. So, and we do see that because the P wave is still consistent, and we do see it at its normal rate, which is about 60 to 100. So you'll see the P waves occurring, but we'll see a completely independent QRS. And that's because since there's a complete block, the ventricle realizes it's not being contracted, and it starts to send signals for its own pacemaker to kick in. So that's why we can also see a narrow or wide QRS depending on the patient, and that's because it can start in the junction, it can also start in the ventricle depending on the person. And the junctional one, since it's still higher than both ventricles and the bifurcation, it is still a more organized depolarization. Sorry. And really, if we see one of the cells over here starting to be its own pacemaker, now it needs to it depolarizes this the right ventricle, and then it depolarizes the left ventricle. So then we see the widening of the QRS. So really, so that nodal degeneration occurs, and we do get the arrhythmias we do see. So I also want to talk about the reduction of the sympathetic and parasympathetic nervous systems actually being able to respond to any sort of like a wide variety of issues that occur in the heart. So if it needs to, if the sympathetic nervous system needs to activate and raise the heart rate, it will, but with geriatric patients, the sympathetic and parasympathetic nervous systems actually reduce in their responsiveness. So that's why we see a constant bradycardic rhythms with most geriatric patients. Their heart rate is lower. We have a lower maximum heart rate, so for stress tests, we'll see lower heart rates even when it is being tested. And we know that it also, with the constant bradycardias and lower maximum heart rates, there is a lowered ability to compensate when need be. It is important to note that we know that constant bradycardias in bradycardic geriatric patients might be also due to beta blockers or any other medication that will artificially slow the heart down. But it's also good to know that the sympathetic nervous system actually reduces in its efficiency in raising heart rate. So bradycardias can also be an intrinsic reaction. So let's make our way to geriatric heart failure. This will be the last portion of our presentation, and really, heart failure occurs because of the other comorbidities involved with geriatric cardiac decline in health. So we know that hypertension is involved. We know arrhythmia such as atrial fibrillation will be involved, and we also learned that vasculature and myocardial disease occurs. And I also forgot to mention that during this fibrosis and the altered cell forms, we also see issues with the valves occur as well. So stenosis of the valves, fibrosis, that kind of thing. Those also affect our valves. They're not immune to the disease process. So when these comorbidities occur, we do see a drop in stroke volume. Hypertension, you might think, will be increased stroke volume, but like we said before, the increased afterload will actually drop stroke volume, and the decreased ability to compensate if need be. So since this is occurring, when we add additional cardiac stress, which could be intrinsic or extrinsic, so it could be within the heart, it could be sympathetic innervation, it could be extrinsic, so it could be involving exercise, running up the stairs, fight or flight reactions, that kind of thing. So any sort of cardiac stress that is added on will increase our MVO2 demands. And since our heart has now a decreased ability to compensate for these demands, heart failure will occur. And that is why we do have increased heart failure within geriatric patients. Okay, guys, so I hope that was all clear for you guys. I do have some questions if you want to continue on, some questions to study, just to help complete your understanding of this topic. So the first one is, why does left ventricular hypertrophy commonly occur without the right ventricular hypertrophy also occurring? There is an answer why of that. I don't know if I actually mentioned that within the presentation, but there is a specific reason why. Number two, how does having a bundle branch block affect our patients? So how does the actual bundle branch block affect the outcome of our patients, their compensation, and the overall appearance of these patients? Number three, also, how can we detect a possible STEMI with the presence of a left bundle branch block? So left bundle branch block is a widely renowned as a STEMI imitator. And just because there is a way to detect a possible STEMI or a probable STEMI through the presence of a left bundle branch block. There is a technique, however, it is still contraindicated for a STEMI bypass. That is more of like a patching point and more of an extra knowledge piece. So thank you guys for listening. I hope you guys learned a lot. And if you guys have any questions, don't hesitate to message me, see me in class, give me a shout, let me know if I can help you with anything. If you guys need any help with ECGs at all or any cardiac questions in general, just give me a shout. So thank you guys for watching, and I hope you guys learned something.